Get started. So welcome to those out there who are watching. My name is Haney Malamat. I'm with the Resuscitation Conference, and I have with me here today a very special guest, Arun Nagdev, who's going to be one of the speakers at this year's or next year's Resuscitation Conference over in Las Vegas. Arun was someone I met when I was an intern, actually, at Kings County Hospital in Brooklyn, and him and the rest of his class were just our gods. We looked up to them. They were amazing, amazing residents, and all we wanted to do was be like them. So I was fortunate to have such great role models at the start of my training. And then he went on and did some ultrasound stuff. So I'm just going to turn over to him and let him tell us who he is and what he's done. And we're going to do some interesting stuff for you tonight. So Arun.
Hey, my name is Arun Nagdev. Thank you, Haney. Haney was my intern a long, long time ago. I went from there to Highland Hospital in Oakland, Alameda County Medical Center. Now it's Alameda Health System. Famous program that's been around for 20-some years, trained some great people, and did an ultrasound fellowship there. And then went off to Brown and started their fellowship in emergency ultrasound, which was actually really fun and interesting and an amazing center with a lot of pathology. And then I eventually came back, and now I'm the ultrasound director and the fellowship director at Highland Hospital. It's a really great place to work. I'm just lucky to work there. It's a fantastic place with a great ultrasound history, tradition, and just people that love what they do and always want to push thought process forward. It's one of the places that was first place to ever do DVT studies and cavitary studies, and really the place where I think ultrasound-guided nerve blocks was born, and it's a place where on every shift I probably do 2 or 3 blocks, and a place that we've probably done more than 500 nerve blocks ultrasound-guided in our department, and we use it for everything. And I could talk about how it's such an influential part of my day, but it really has. It's a great place to do ultrasound. I'm very lucky to be there.
That's awesome. Now you're really well tuned into the national and international teaching circuit for ultrasound, and I want to ask you, how many people do you think out there right now, realistically, are doing ultrasound-guided nerve blocks as part of their daily practice? I know you might not have hard statistics, but what do you guesstimate?
So I think it's interesting, right? I think that we've been doing it for 10 years, and it's scary to say that, 8 to 10 years, and I think there are probably just a few centers doing it actively. I would love to say that a lot of people are doing it. I think femoral nerve blocks are something that can really catch on and be used clinically by a lot of different places. I want to say there are a few, not a lot. There are a few centers led by a few really progressive doctors and hospitals who are willing to do this and to give patients better care. It's such a game changer for me. I will tell you, there are very few things in medicine that I've done in my entire career that is as satisfying as reducing somebody's pain right in front of you without putting them to sleep or making them apneic. And it's I think there's probably maybe, I don't want to guesstimate, maybe 5, 6 centers in the country. There's probably a few people are doing it. And again, it's weird because at our center, I haven't done a procedural sedation in a very long time because we just block everything. So it's just bizarre to say that, but it's changed our flow of our department, and I think it's something that most centers can integrate if there's one person who's willing to be the point person to really push it.
So why do you think it's so slow to adopt? I mean, I know somewhat about it, and I gotta say I'm not doing it as a mainstay of my practice. But why do you think people aren't just picking this up or going out and learning it? Is it just the older generation of people learning ultrasound, or is it just an inherent fear that they're gonna inject lidocaine into the artery? What do you think it is?
Yeah, I think it's both. I work at a small community hospital by myself, just to moonlight 2 days a month to kind of make sure that I can still do my chops. And actually, I block more there. And the doctors who I work with, I've been teaching them femoral nerve blocks. And I think for them, it's not even a thought. Like, they don't even think about doing it. And then when I show them how simple it is and how effective it is, A, they recognize how simple it is, and they're surprised. And B, they recognize that it causes such a dramatic difference in their patient care that they have started doing it. A few of the doctors are not actively doing it. I think it doesn't get integrated for 2 reasons. Stuff comes down from academic centers, and when your academic center is reticent to let you do blocks, it's really hard. When I was at Brown, we did a study on femoral nerve blocks simply because I wasn't able to do blocks in the department. Our anesthesiology department wouldn't let me. So we went to the IRB and started doing blocks to kind of circumvent this process and then publish this paper on it, which is kind of ironic. So I think there are a few centers that really inhibit it. We've been trying to publish a lot of literature, and we have a kind of a large case series, which I'm sending out eventually. It's still on my to-do list of more than 100 and some blocks that we did successfully with 42 different providers that showed efficacy. So I think once more and more literature comes out, I think more and more centers and more people will feel comfortable. And I think it's that, I mean, I hate to equate it to drug use, but it's the gateway drug. Like, learn the femoral nerve block, and you'll start recognizing the beauty of it, and you'll then be able to kind of work your way through different aspects of the anatomy. And plus, it makes you amazing anatomists. You learn anatomy all over again in this profound way that I'd never learned before in medical school.
Yeah, I think you have to go back and review some of the stuff that, for me, I just kind of blew by during anatomy, and it's like, hopefully I'll never have to learn this again. But for some things, especially the femoral nerve block, it totally blows your mind just how good you can make people feel when they have really, really bad injuries, and dilaudid just not going to cut it.
Yeah, I mean, just I worked 4 nights in a row, 4 swings in a row, and every night we've had a couple cases. I had a lady last night who had a large abdominal wall abscess who came in diabetic, and we really didn't want to admit her. She wanted to go home, and we did a thing called a TAP block, which is a transverse abdominal block. It's this block where you kind of go in and place fluid in the transverse abdominis muscle right above it. And it sounds complicated. It's really simple. I have my residents do it. And in 10 minutes, she's completely insensate to her abdomen. We cut into her abdomen, pull out some purulence, start some antibiotics, and get her home. I mean, that would have been a complete cluster where I would work somewhere else. And again, maybe that's not something everybody's going to do, but it's amazing how much it changes your practice. Shoulders, reductions. We've kind of moved away from doing procedural sedation for shoulders, and now we do these small injections just on the C5 plexus, right on the top part, just 5 cc's. Get them comfortable, maybe give them some benzos, and pull it in. And it's amazing how quick it is and how it's just done at the bedside. And it prevents that whole process of getting the person to a room, starting procedural sedation, paperwork. And I think, from at least the literature in the anesthesia world and from our literature, I think it's fairly safe. And the beauty of it is that it can be done at the bedside. And it's amazing. You do learn a lot of anatomy, and that's the fun part of it. It's great to understand the pathophysiology and the anatomy, because if you know anatomy, you learn the pathophysiology.
That's awesome. So give us just 5 of the, you've given us a bunch already, but give us 5 of the top nerve blocks that you just do all the time on a given week. Which are the top 5 that you're just always doing?
So I think the femoral nerve block is great. It's interesting. I work at a center. We don't get a lot of the old lady hip fractures, but we get a lot of gunshot wounds to the femur. We're just published a case series that's going to be with our orthopedic service, looking at 33 cases. So we do a lot of those. They come in the trauma bay. It's A, B, C, D, and then femoral nerve block. And we block these guys up front. But again, if you work at a center, like especially in the Northeast, where I saw a ton of fractures, you could walk into the room, diagnose the fracture clinically or with an X-ray, block your patient, then she gets the Foley, etc. And I think it can be done for everybody. Second, I think we do a lot of shoulder reductions, and we do a lot of interscalene blocks for shoulder reductions. It seems complicated, but I think if you break it down, it's not that difficult, and it can be really done over and over again. Then we do a lot of posterior tibial, which we have a lot of lacerations to feet. This is a 5 cc injection by the calcaneus, by their medial mal, and it completely gets your complete plantar surface insensate, which is great because you can now repair things, you can numb them up, you can do whatever you want to do. Forearm blocks are so popular. We get a lot of boxer fractures. It's 1 injection. You can hang your patient and let them reduce their 5th metacarpal. That's probably the most. I can't think of it. And we do a lot of sciatic nerve blocks, the distal sciatic and the popliteal fossa. I think it's a little more complicated. I'd want to say it's an easy block, but I think it's one of the more advanced blocks because you have to really get into that space. And I think it's been difficult for some providers. That's about it.
That's awesome.
Actually, one more. Can I cut in one more? I think it's a fantastic new block I love this block. So we do a superficial cervical plexus block, which is right on the outside of your neck. It's the plexus that kind of covers this area. What's great is any lacerations, ear lacerations, and we started doing for central lines. So all our patients
Really?
get central lines, get a 5 cc, 5 to 10 cc injection in their neck before we start, and then they're completely insensate all the way down to their carotids.
Wow.
And it's great because you actually do this procedure, no flinching, no pain. When you dilate them, it's great. So there's a lot of different uses, and I think we're still at that stage. We're still figuring it out. But I think that's my goal, is to make this simple, and everybody else can use it.
So just tell us where that last one was again, because we do so many central lines. I think if you can, even for the sick people, if you can just get us on
Yeah.
board with that and convert a couple people, that'd be great.
Yeah, it's a superior cervical plexus, and I'm not going to describe it on my neck, but it's a little bit higher. It innervates it's kind of the cape distribution of your neck. I can give you a link to our website, and it actually goes through a step-by-step way to do it. It's highlandultrasound.com, and we have one of our residents. We layer to the side. We actually show you how to do it. And what's nice is it's used for endarterectomies. So it's great because you can actually do this for central lines, and it's literally 5 cc's, 25 gauge needle, a pretty simple injection. You're injecting actually posteriorly right underneath your sternocleidomastoid, about the level of the thyroid. You go right underneath, and you're just opening that space up. A lot of people do this blind. It works really well. We do it for clavicle fractures. We get a lot of those. They're really uncomfortable. Works for the clavicle really, really well. Lacerations, IJ placement, inferior lobe lacs, and it works. It's impressive, and really cool block. And it's not hard. I've walked numerous med students through this block.
Awesome. So you're motivating a lot of us by saying if a med student can do it, then and then
that's not fair.
And that's highlandultrasound.com.
Yeah, one of our previous fellows, who's a master at this stuff. This guy is probably the most knowledgeable person I know when it comes to ultrasound guided nerve blocks. This guy's crazy. He just spends his entire life devoting himself to this stuff, and he has a site going up. But we give him videos, and he kind of really talks his way through it. He's fantastic.
Awesome. And of course, you're going to be going over some of this at Resuscitation in March 2014.
Yeah. I think the thing that is amazing, I get to work at the center with some really intelligent people who really push this, and I always feel that I'm not the smartest person in the world, but I can make difficult things easier, and kind of in an audience where people are like, okay, I could do this, and that's the key, right? Making it simple and something you're gonna walk out and go, I could do this, and you can. I did the same exact similar lecture in Ireland at the Royal College, and one of the residents that night went and did a femoral nerve block and really pissed off the entire department, but did a fantastic job. The patient had great analgesia, and she comes up to me the next day and says, it was simple. You showed me how to do it. I can do this. And she went and did it, and she was a PGY2, and it was great.
It brings it all home, right? Makes it all worth it, all the teaching.
It makes you happy, right? You're like, I actually did something that changed somebody's pain score, rather than getting
Good to do that. All right, I think we lost Arun. Let's see if we can get him back on. All right, here we go. Sorry, folks. He should be joining us any second.
Hey, sorry about that, Hanny.
There he is. All right.
I don't know what happened there.
No problem. No problem. I was going to blame the Baltimore cold weather on it. It's only 40 degrees. How warm is it over there now?
I think it's like 65 today.
That must be nice. Must be nice. There, you got the fireplace going in the background. How cold it is. Anyway, what's that?
Today.
What's that now?
I'm gonna have to wear a long sleeve shirt today.
Oh, that must be hard. A tear rolls down my eye. So listen, why don't you take us through some femoral nerve blocks? Show some of us at home how to do this and how you approach the patient.
Yeah, let me do this really quickly. This is these PDFs that I think he's gonna send out, and I try to make these as simple, and I hope everybody can see this. And it's a linear transducer, and I kind of make some simple supplies, and it's not a big deal, and we'll talk about this. But the key for me, and I'm hoping everybody can see this, is really to get the ultrasound machine contralateral to the block you're going to do. So you're visualizing the screen at all times, and it's that classic anatomy. It's the nerve, artery, vein, and you're having it in the femoral groove, in that inguinal groove, excuse me, but a little bit higher, just a touch, because when you go a little bit higher, the artery and I'll show you a picture of it, is right here, and this is your nerve. And it's that triangular shaped thing. And I'm not going to tell you where the nerve is because I don't know exactly where it is. It tends to lay right on top of the iliopsoas. It's right here. It usually sits right here. And a lot of this is just fat. So we've kind of talked about this over and over again. This is the fascia iliaca. And we get into big discussions about this at work. I mean, this is like argument stuff for us. The key for me is I want to be as safe as possible while getting to that nerve. And the key thing for me is getting underneath this fascia iliaca. And I'm going to show you a little video after I show you these slides. The goal is to get the needle to come in this direction, pop through the fascia iliaca, and once you inject fluid, fluid will track in that fascial plane down in this direction and down in this direction. What I used to do was I used to come right at the nerve and pop underneath the fascia iliaca, and I just think it's probably okay, and the literature would probably support me. But I think just to be safe, you know, there's a lot of really smart people who do this. Some of the consensus states that you should probably stay away from there. So I try to come down here, right at the corner, and inject, and you can see that anechoic fluid spreading. You can see how shallow this is. This is only about 1 centimeter or 2 centimeters deep. Most people are not more than that. And so the goal is, I call it in-plane needle visualization. You can see from the slide, the needle's coming down and injecting fluid underneath this fascial plane. Once it gets underneath the fascial plane, the fluid will track in this direction. Again, I would have come in probably a little bit lower on this one and let it slide down, but this worked perfectly. You can see the corresponding image right underneath. And I'm going to just go ahead and play some video that corresponds to this. Let me pull it up 1 second.
So while you're pulling that up, let me just ask you, are you doing this with Sterile Technique?
So, you know, we initially started doing that. Now we're not. We're just, I use a tegaderm if you'd like. I think some people like to use a tegaderm. It's one injection. I clean the area with chlorhexidine. I don't do a lot of, don't do a lot of stuff other than just kind of some basic, close everything down as it all opens up, is all blocks I'm doing. And here, I'm going to show you some video. So it's a great question. Can you see that, Hanny?
Yep.
Yeah, so you can see this needle coming in the top. And see how I'm injecting? And the fluid's sitting on top of this fascial plane. This is the mistake I used to make when I used to do these blind, or when I first started doing these. Now I'm below. You can see how it's gotten below that fascial plane. That's probably the key. That's not great needle visualization, but I'm below this thick fascial plane and now injecting. And this is probably the nerve right here, this triangular structure right here. I'm going to go to the next slide. And again, you can see, again, a little bit of air is going to be injected, again, above the nerve. You can see here's the fascial plane. Here's my needle tip. Here's the nerve complex. Here's your femoral artery. So I'm above, and I'm not going to get anything. And now I'm going to go right underneath that fascia and inject. You can see that needle again right there, underneath, and that fluid's tracking. Again, I would recommend coming a little bit more here and breaking a little bit farther away from the nerve, just because the last thing you want is nerve injury, even though the data on nerve injury is, again, very, very low. I still think it's the right thing to do. And again, you'll see here, here's a needle on the other end coming in, and it's, again, underneath that nerve complex, right over the muscle, and that anechoic fluid is spreading in this direction. It's a really nice way of getting simple anesthesia. A lot of times we'll use these control syringes. If you want to just do 10 cc's, you can also hook up a 20 cc syringe just to a little catheter. I often don't even need this long spinal needle. You'll get away with a 21 gauge needle or 25 gauge needle because it depends on the patient's body habitus. Here's the other side again. Here's that fascia iliaca. Actually, the fascia iliaca drops down here, goes underneath the artery. Here's your femoral nerve. And then as you inject, you've broken that fascia iliaca, and that fluid tracks in this direction, and your nerve sits right here. The benefit is it works in about 5 to 10 minutes. I'm just going to get you back on my Google Hangout. And what's nice about it is you get a good amount of anesthesia. Again, you won't get 100%. If your anesthesiologist comes downstairs and says the femoral nerve block does not cause 100% anesthesia, he's right. He or she, excuse me. What he's trying to say is that for operative care, to get into the hip, to do an operation of the hip, you're going to need something higher. You're going to need an L2 to L4 block. You're going to need a spinal. But what we're doing is pain relief. And so a simple way of doing that is getting one of the three nerves that come out of the L2 to L4 region. One is a femoral nerve, and you get about a 50 to 75% pain reduction for femoral fractures, for intertrochanteric fractures, all the way up to the knee joint. So I've had a case where I've had patellar fractures. The patient's really uncomfortable, it works. I've had a patient that comes with a distal femur fracture that the orthopods are comfortable that it's not giving a compartment, and those work really well.
That's awesome. And tell us again what anesthetic you're using and how much you're given.
Good. Yeah. So these are all good questions, and these are questions I'm going to try to go over in the lecture. So the two big anesthetics people talk about are either lidocaine or bupivacaine. That's what we get in the ED. And I recommend lidocaine with epi for all blocks, unless you're really comfortable. Lidocaine in the vein or artery in an intravascular injection probably doesn't do much to somebody. And we do it all the time, right? You inject lidocaine for our theoretic VTAC patients. We do it in codes. We did a lot before in the codes. Bupivacaine, the problem is bupivacaine is a sodium channel binder, but it binds for a long period of time, kind of like TCAs. So when it binds for a long period of time, it causes CNS and heart toxicity, and that can cause, they call it local anesthetic systemic toxicity, or LAST. So I recommend if you're really, really comfortable, if you're doing with me, if you're doing with probably with Stone, if you're doing with some other people that are well known, or people who are really comfortable, and you have great needle visualization, go ahead and use bupivacaine. Then you got to also have the antidote with you, and we have this lipophilic molecule that we have in our ED at all times. It's inexpensive; anybody can get it. Conversely, if you're not, use lidocaine with epi. Lasts 4 hours, safe, has low side effect profile, and you can always get away with it. So if I'm working by myself and I don't even have bupivacaine, I'll use lidocaine with epi. It's not a big deal.
Cool. And because you're going right at the nerve, I guess you're using about 5 to 10 cc's.
So I'm doing about 5 to 10 in and adding about 10 more on. So I'm doing probably about 20. Even though I think I can get away with it 10, I think as a novice provider, you're going to need a little bit more. So if my residents do it, I let them do 20. If I do, I can probably pull it off with 10, but I think it's just me being a little bit arrogant.
Well, you're probably getting a little closer to the nerve than
probably. But I would recommend 20, so I think is probably the right answer for that. Yeah. If you look at the literature, they used to do 30 to 50. Wow. It's like large volumes, and we don't do that anymore because I just don't want to push 50 cc's into anything.
Right.
Yeah. So yeah, it's great. I mean, there's some really simplified techniques. I think this can make your life much easier. And again, I think this can be integrated into every ER tomorrow. I really, really believe it can be. And it's not difficult. It's simple, and it's great, satisfying.
Excellent. That's awesome. Do you have any other blocks or any tricks you want to share with us?
Yeah, we can talk about hip taps. We've been doing a lot of these. This has been something that has been kind of happening a lot. We've been picking up a lot of infections easily. We've been scanning hips and then just tapping them if we think it's an infection. Something I never did as a resident. I mean, we did residency at Kings County together. None of us would have shoved a needle in somebody's hip if we thought it was a hip infection. That would have never happened. We've gotten to a point where we've actually started injecting steroids in people that we think don't have hip infections. And again, that's a little bit, again, Highland-esque, where we kind of push it a little bit. But we've done 50 of those really successfully. So I can kind of go over that really quickly. I think arthrocentesis is something that is really the privy of the ER physician. There's a great paper that came out about a year ago, and they talked about arthrocentesis is the LP for meningitis, and it's something that if you think about it, you should stick a needle into it. The hard part is all of us have shoved a needle in something in whacked bone a bunch of times and just not been too excited about doing it. So I think that let me pull up some hip stuff for you guys real fast. Hopefully this pulls up. There we go. So again, this is a really nice technique to get into the hip, and what's nice about it is you can actually just look to see if there's an effusion, and the kind of the ways, again, it's that same inguinal ligament. Your probe marker is facing to the right of the patient, and you're going to classically see this. You can see the femoral neck as this hyperechoic lucency with the femoral vessels right here. It's artery and vein, which we're all comfortable with in this area. And then all you got to do is rotate that probe marker towards the umbilicus. So you're going to start in this direction and kind of pop it right to the belly button. What's nice about that is then you get this longitudinal view of the hip. And what's great is you see that femoral head. Here's the femoral neck, and this is the iliofemoral ligament that wraps over. And this is this little recess. something that took me a long time to figure out is when we're tapping a joint, we're not really sticking a needle between two bones. What your goal is to tap the synovial fluid that's encased in the ligament. So it's really just not sticking a needle between two bones, if that makes any sense. It's really getting into the joint space. So it's a joint space tap, not really a bone tap. Does that kind of make sense, Hanny?
Yeah.
And the idea is, again, you're contralateral, you're seeing the screen clearly. This is a little different. You're going to have to be sterile for this procedure because you want to be into a joint. So we always cover, never tap a joint that's a prosthetic because you need full sterile precautions for that. We only do it for non-prosthetic hips. Again, you're visualizing the screen, you're in the same plane, and again, this is another in-plane tap, and you can see right here is that anterior synovial recess. This is your iliofemoral ligament, and that's that fluid you're looking for. And again, the needle would come down in plane and bump right into this space, and you'd aspirate. And what's nice about it is it's not that difficult of a tap. Again, you come down all the way through. There's a small effusion here. You probably don't even need to tap that effusion. This person did have a hip effusion, and we tapped it, and it was negative. But we picked up like 3 or 4 of these that come in with knee pain, fevers. I had my fellow just had a kid that came into when he was working by himself up in Santa Cruz with fever and couldn't roll over, put the probe on, tapped the hip, pulled out pus, and transferred off to the academic tertiary care center. And they were impressed with the fact that he was so comfortable being able to do a hip tap by himself at like 2 in the morning. So this is another technique. And again, I was going to go through during the lecture all the different joint arthrocentesis during Resus.
That is really, really sweet. One thing I noticed is that I'd always seen it done with the linear probe. I suppose with our population of adult patients and habitus that might be difficult, and that's why using the curved linear probe is preferred.
Yeah, so it's for, let me get back on it. It's for kids. I think it works really well with a linear probe, but for an adult, you're going to use a curvilinear. And so we started doing this hip tap clinic, and we were injecting steroids into 400-pound patients' hips, which sound ridiculous, but with the ultrasound machine, it's not hard. So the curvilinear for anybody is probably greater than 2 or 3 centimeters deep, which is most of our adult population. I have used a linear probe in a really, really thin patient, but most commonly it's a curvilinear probe.
Wow, that is awesome. That is awesome. Yeah, we always have to call orthopedics, which can take anywhere between 2 and 3 days for them to come down. So that's a really, really cool thing that I like to try on my next shift.
But I think what's more interesting, at least to me, is just localizing it. I mean, I think a lot of times, if you don't see effusions, along with my clinical exam, I think I've reduced my post-test probability. And I think it's something that I've done over and over again. We see a lot of these ankle cellulitis, knee cellulitis, you have an effusion underneath, putting the probe on and knowing where to put it. And I make these little cards, so my residents have them on their iPhone. They all put them in Evernote and put them on their, so they can visualize it. Once you know the anatomy, and once you know where the probe goes, you're like, that's not an effusion in the knee, that's not a effusion in the ankle, I'm not going to tap it. And I can't guarantee you that you can't have an effusion and don't have an infection, but it's pretty hard if you don't have an effusion for somebody to get a tap anyway. So if somebody's febrile, warm, tender, fine, you're done. But if you're kind of in between and you don't have an effusion, I don't think any of us are going to stick a needle in it anyway. So it's a really nice way to prevent a lot of unnecessary stabbing at people.
That's fantastic. That's fantastic. Some great tips by you today.
Yeah.
So that's really cool. So we picked up a bunch of stuff from you in terms of just kind of expanding our reach with ultrasound, things that we can do that some of us might not have known that you can do, and then walking us through a femoral nerve block and then a hip arthrocentesis, and also for the great resources. The website is highlandultrasound.com.
H-I-G.
Right. Yep, we'll post it up. We're gonna be this will be going to the Center for Resus website. That's www.center4resus.com, and we'll be posting this as well as some of the resources that Arun was discussing and those websites on there too, so you'll have the resources. But most important, we want to stress that, you know, come down to Resus in Las Vegas in March 2014, where you can see Arun talk about this and attend some of the workshops that go on this in the afternoon, so you can get your hands on this and then take this information back to your next shift and use it to help reduce patients' pains and hopefully stop tapping hips if you don't need to, or calling orthopedics to do things that you could do at the bedside. Right, Arun?
Yeah, do you want me to show you one more, Handy? You want me to show you how to do a posterior tibial nerve block? This is great
Yeah,
for all the foot stuff that you have. This is something that makes a big difference, I think, when you're, let me pull it up. Let me get it up. Femoral. Here it is. So you can imagine how many of us have had people that come in with lacerations to their foot, or you're digging around. I still remember being an intern or a second year in Fast Track where I was holding down this lady's leg while I'm trying to inject anesthesia into her foot, and every time the needle came close to her foot, she moved, and it was just like such a cluster. So this is a great block. This is the posterior tibial nerve block, and the posterior tibial nerve innervates pretty much the entire foot. I'm going to thank one of our nurses for donating her foot to science, and you can see it covers most of it. I'm not going to discuss the other two nerves, not really that relevant right now. And we know the posterior tibial nerve comes this way, right next to the medial malleolus, right by the tibial artery. And this is classically done blind. My chair does this blind. There's a nice study in the anesthesia literature where they compared this blind block versus the ultrasound-guided block, and the ultrasound-guided block was much more successful. I mean, a lot. It was impressive how much more successful this is. And what you're doing here is you're going to get your patient to either kind of frog leg it and lift it on a little towel. There's a little towel underneath. You can't see it that well. There's a towel right here. Or have them roll to their side, whatever's comfortable for them. But you want a clear view of this medial mal area because you know the nerve runs right here, right by the medial malleolus. This is going to be a linear probe, and I always start distally. I start and I find the medial malleolus right here, and I slide up the leg. By doing that, you will start recognizing the nerve. So again, I'm right here, and you'll see the medial malleolus right here, or it's a distal tibia, however you want to call it. And what you're going to do is, as you slide up, you're going to see this vascularity, right? You're going to see the artery. You'll see it on your ultrasound clearly, and right next to it's going to be the nerve. This is tough to see on this one, but when you scan in real time, you really will see this little bundle that sits right next to the vascular bundle. It's the posterior tibial nerve. And then as you slide up, you can do it either way. You can do it out of plane, which is some of our residents like, because there's really not much room in this area. There's the Achilles right there. They come out of plane, so you're not visualizing your needle. They're dropping M mode in because what they like is they like to center. The center of that little line is the center where the M mode is, so it's nice to know exactly where you are, and they come like almost a 90-degree angle and come in and inject. And when you see the fluid track in the fascial plane, you've got the block. Or you can do it in plane. So again, this is where your needle's visualized, and as you watch the needle come in and you inject, this fluid will kind of wrap around. It doesn't have to be perfectly all the way around. The benefit of this fluid is it's lipophilic, and your nerve is covered in fat. So this is slowly going to seep in. Give them 10 to 15 minutes, and you'll get a nice block. And the beauty is, so this entire area, the area of the body that I have no idea how to anesthetize, is done with 5, 6, 7 cc's of lidocaine with epi. The patient's comfortable. You can irrigate. You can look. You can do whatever you need. You can suture. I mean, it's a fantastic block that every ED doctor who's working by himself and has a laceration of the foot freaks out about. This is it. You're done. This is a simple way to do it, and a really nice method. Is that useful? I lost your sound, Hey. Let me see where you are. Hold on one second.
No, that was me. That was me. Sorry, I was muted. I said I've done that before, and it is truly a game changer when you take that patient who everyone's trying to hold down. You're like, just one more second, and it's not 1 more second. You're lying to yourself and the patient. But that block is a game changer. So
and getting anesthesia itself, it's impossible. Sticking a needle into the sole of your foot and shoving, and fluid doesn't track. It's that fascial plane so tight there. You're shoving in a needle and then pushing as hard as you can. That's got to hurt. Like, I wouldn't want that. And a simple block, it makes such a difference. And like the lady that we did the tap block for last night, she was like, I cannot believe that this was so simple. She's like, it didn't hurt. I felt great. And she walked out of there, and I started her on pain medication before her pain started. It really is, having patients tell you they're so impressed and so happy with the level of care they get is really, it's impressive. And I always tell this one story when I was, and I'm going to end it after this one story. I'm sorry I'm babbling, Andy, but I was working by myself in this little ER about an hour and a half from San Francisco, and this young guy who was a machinist unemployed, I mean not unemployed, but uninsured machinist came in and he had a complete, he put his hand in this machine and kind of pulled off the entire skin on his anterior hand, and he's screaming in pain. The other physician was the chair of the department, was giving him Dilaudid and transferring him to another center because he had fractures. And he had a 2-hour flight time or whatever, and I was leaving, and I was like, hey, Greg, what's going on with this guy? He's screaming. You could hear him, I mean, screaming in the ER. I walk over, and his mom and his sister are sitting there, and they're crying because he's literally screaming in pain. This guy is 14 Dilaudid into it, screaming in pain. And I was like, I'm just going to block him just because he doesn't, they're going to have to repair this. So 10 cc's or 15 cc's later of lidocaine, he gets almost apneic, he falls asleep. And his mom comes over, crying, comes up and gives me a hug, and she's like, thank you. And very rarely does that happen in medicine. Very rarely do you feel like you actually made a huge difference. And fine, maybe I saved an MI here or there, but really made this guy go from torture, and his family probably listening to him screaming for an hour is torture, to changing his path. And it's really profound. And this happens every couple days in our ED.
That's awesome. Yeah, that we forget sometimes that our jobs aren't just to hand out work notes and give prescriptions for Percocets, but really to help people. And that's a great story. That's a great story. You totally changed them, and I'm sure they'll never forget you. And emergency medicine benefits as a specialty by that kind of stuff. So
your job satisfaction just goes up tremendously when you feel like you can actually do something rather than ask somebody else. Like, I need orthopedics down here right away because it's hurting him. I need orthopedics down here right away. The ability for you to have that conversation with orthopedics, relieve the pain, the patient is comfortable till a consultant comes, or when you transfer. And for the single ER doctor, it's game changing.
That's great. That is great. Well, I'm really excited now to see you speak at Resus and attend the workshops, and I'm looking forward to the resources up on the website. I want to thank you for your time today. This was really, really awesome stuff. And I hope people out there, they can still tweet in their questions. Hopefully we can forward them along. We didn't get any tonight just yet, but please send in your questions and I'll forward them along to Arun.
Yeah, thanks, Hank. It's getting dark back here. I'm starting to lose it.
Yeah, was it going to drop down to 55 degrees, get really cold over there?
Yeah. It's going to be 58, yeah.
Well, great seeing you as always, and thank you for your time.
Have a good night, Hank.
All right, you as well.
Bye.
Take care, everybody. Bye.
Bye.